Okay, well, that is always my cue that I need to get started with today's session. So welcome to our early echo series. We are thrilled to have you here. If you've not taken a minute, please put your name and contact information into the chat. We are recording today's session. They are on our Canvas page as well as our YouTube channel. So we use those for educational and quality improvement, as well as able for you guys to share or go back and review some of the information. Sometimes we're talking about some sensitive topics and it takes a while to digest that. So please feel free to always go back and utilize those. Echo is an interactive community, so please put your comments into chat. If you are feeling comfortable, turn on your camera so we can see all your smiling faces. It's always a great way to try to get to know everybody in Zoom world. We also have a great way to get valuable resources, and that is through our case presentations. If you have a family or a client that you're working with and you just want to brainstorm with all of these amazing people on the call, please reach out to us and consider doing a case narrative discussion, whatever you want to call that, talking about our families. We all do it, and we all work with some families that we need some ideas on. So if you would consider doing that, we'd be greatly appreciative. Again, we do talk about some sensitive topics, so if you will avoid identifiable information, so no first and last names, no addresses, anything that you wouldn't want shared, don't share it with us. Key components of an echo session are, of course, our amazing didactic speaker that shares some information with us. And then we do a case presentation and get all of your guys' amazing recommendations. Those recommendations that we send back to you. So Cashel, you're on my screen, so I'm calling you out. Sorry. If she was to do a case, she would then get a list of resources, as well as all of those resources are on our Canvas page, so anybody can go back and look at some of those ideas. The other thing that Echo is doing is really just that professional networking. So knowing that I can reach out to whomever on the call and ask them follow-up questions. So again, Cashel, you're on my screen, so you're the name I'm calling. I can see your smiling face, and but she shared something and I want to reach out to her. So I now know that I can do that by attending this echo session. And that's where we ask if you will please rename your profile and what your discipline is, if you are comfortable in doing that. Raising your hand, you can always do that, but we also just encourage you to put that information into chat. One of our amazing hub members that has an asterisk in front of their name, or now they will be reminded to have an asterisk in front of their name, like Rebecca. I just saw her turn to her computer screen. We'll always monitor those chats. To get a credit of attendance, we do ask that you fill out the survey. We will be dropping the survey link throughout today's session in chat, and that's how we send out our certificates. Case studies, Canvas page is where we store everything. So if you would like access to our Canvas page, please just shoot us an email and we will invite you to that. Case studies, again, are a great way to just hear from everybody on this call. I love when I get to present a case that I'm working with, because you guys all have amazing resources and information that helps me then provide more appropriate services to the families that I serve. We have our Facebook and social media, so if you want to take a minute and follow us, We share resources, information about upcoming sessions, or anything else that we get shared with. So I'm really thrilled today to have Jamie Seal present to us. So I'm going to stop sharing and turn the time over to her.
Great. Okay. So hi, everyone. Jamie Seal. We're going to talk today a little bit about supporting medically complex children with kind of a palliative perspective or palliative approach. I'm really hopeful today. I think there are a lot of different ways that we could have this discussion today and different things that we could cover. And I could easily talk for a very, very long time about it. I really am hopeful that you all will tell me what you're hoping to gain from this. If there are questions that you have, please interrupt me or put them in the chat, whichever works, and let me know how we can move this conversation forward in a way that is helpful to all of you. As far as disclosures, other than I have the cutest dogs, nothing that I need to disclose today. And I'm hoping my objectives for this, but again, I think more important are what your objectives are as well. And I would like to be able to kind of define what pediatric palliative care is for everyone. I think there are some preconceived notions about who we are and what we do. And I think some missed opportunities for some of the supports that we can provide. Review which children qualify for palliative care, what we can offer for these children and their families, to discuss how to support medically complex children and their families using a more palliative perspective, and then highlight some of the common communication strategies that we use when we're working with these families to help really understand who they are and where they're coming from. A bit about me. So I have been working in the neonatal field for about 24 years, palliative care for the last 9 of those years. And my passions are things like ECMO, heart-lung bypass, cardiac disease, palliative care ethics, and communication education. So I'm an APRN nurse practitioner on the Rainbow Kids palliative care team and also in the primary children's newborn intensive care. I'm a Vital Talk faculty educator, which is the national program Mastering Difficult Conversations. If you've heard of that, that's who kind of developed that program. And then Intermountain Health Ethics Committee, kind of their broad one, not the just localized at the Primary Children's Hospital. I am Tiffany and Roxy's mom, those cute little puppies there. I'm also the medical director of a pediatric oncology camp, and my personal career actually arose from a family event. Both my NICU and my palliative care experience really started with a personal family experience. So for anyone who has not heard of Rainbow Kids palliative care team, or if in the oncology world we're known as the Supportive Oncology in Adolescents and Pediatrics, or the SOAP team, we started in January of 2007 with Dr. Joan Sheets, Beth Nordforth, who is an RN, and Tony Sherwood, an MP. We have since expanded to upwards of 8 physicians. We're looking for one more, 5 practitioners, looking for one more, 3 registered nurses, a social worker, a mental health therapist, child life specialist, and a chaplain. So we've grown quite a bit. We've also expanded from our inpatient consultation service to an outpatient clinic now at the new Lehigh campus for primary children's. And our referrals come from a variety of places. So obviously your primary team when you're inpatient, but many of the specialists at primary children's, and then community physicians, as well as other providers of a child's healthcare team and families themselves will seek us out when they're needing additional support. I used to keep track of how many families we had served. We've still are tracking those numbers, but we're well above 2,000 at this point, and growing every single day. And our age range is pretty wide. So we serve from prenatal, meet a lot of our families in the fetal clinic, and we carry on through our oldest child so far. Child is 36 years, and some of you may know that that is related to the fact that a lot of these disorders, specifically cardiac, tend to be really only known by pediatric providers. Oncology is another field that there are certain cancers that are pediatric specific. So we do see people that are much older than our typical population. So we have a pretty widespread. And we see all of the children that would qualify to come to primary children's. So really that 6-state area that we cover, if you could qualify to come primary children's, you are certainly welcome to be referred to our team. So what is palliative care? I think that a lot of people have the misunderstanding that palliative care is hospice care, and that's what their mind immediately jumps to, and it's actually different than that. So some of the definitions I will touch on really quickly is, I think, curative care. I think we all know what that is. People come into a hospital or to a medical center really helping to eradicate their disease and eliminate the condition, treat the condition, and walk away with a cure. That is always our hope. Unfortunately, not always an attainable goal. Then there is hospice care, which is this multidisciplinary care team that is designed to ease the physical, emotional, and spiritual suffering of patients and their families, which, if you look at the palliative care definition, is the same. But the key there is during the last 6 months of life after the decision to forego curative care. So really, families have to decide that this is, okay, you know what, we no longer have a curative option. We're going to forego those things, including things like seeing your primary care physician, those sort of pieces, and focus on comfort and dignity and, quality of life and pain and symptom management. The benefit for children, thanks to a program that started with Medicaid, is that many of them qualify for something called concurrent care, which is the benefit of allowing hospice care at the same time that you're seeking a curative care treatment, which is really, really beneficial because our children are incredibly resilient and surprise us all the time. And while you might be able to say in an adult patient that has, say, stage 4 pancreatic cancer, you have 6 weeks to 6 months to live at most. Our children all the time are kind of saying, yeah, I know you think that, but we're going to do some different things here. And so being able to have that at-home support that a hospice team provides, being able to meet that team before you're in your end of life phase and being able to develop a relationship is a huge benefit. And nobody complains when we are able to graduate people off of hospice because their cures found and we have a curative treatment for them. Then palliative care is something I like to kind of say enclose all of this. So palliare actually is to encloak or to encase. And that's how I picture our team. So multidisciplinary team, again, designed to ease the physical, emotional, and spiritual suffering of patients and families. We work from time of diagnosis, and it doesn't need to be a potentially life-threatening or potentially life-limiting illness, through life, death, and bereavement if necessary. Although many of our children are surviving and thriving. And I hope that all of our children are thriving. I think that's one of our biggest goals. But we do have quite a few that are surviving. They're not all heading to end of life, but the initial referral does need to say this could potentially be life-threatening or life-limiting. The way that we like to see and describe how we do our role is like a tree. There are lots of branches on this tree and lots of different things that we can contribute to. And each family can choose, do they want to do kind of what our nurse practitioner here is doing, hug the whole tree, take the whole thing in, use all of our resources, or are there certain branches of this tree that are more important to them and really where they want to focus? And so we look at things like advanced care planning. So that might be your code status. If your child's heart were to stop, are we going to provide CPR? Is that not something that's in alignment with the care that you want for your child in their future? We talk about end of life care, if that is where things are headed. And to be honest, we do try to touch on that for every family, because I think it benefits all of us to think about, what does a good death look like? We talk about medical literacy, and this is a huge component of what we do. As you could imagine, you've been there, you've given families lots and lots of information, and you see that kind of, oh my goodness, what are we doing? What did you just tell me? It's a lot to take in. And so we take some time to spend with the families to say, what is it that you heard? What more do we need to understand? What do you understand about, like, have you ever even been in a hospital? Do you know anyone that's had any sort of illness, or is this your first experience? We go through a lot of those pieces to make sure that the information that these families are receiving is helpful and is making sense to them and is relevant to them and their child. We help them delineate goals of care, which we'll talk a little bit more here in a minute. We are kind of from start to finish. So I like to tell our families that, once you've got us, you're stuck with us forever, because we don't go away. We are a piece of continuity, and we are involved in all aspects of your care to some degree. Again, depending on what you feel like you need. And then one of the biggest things that I think people really refer to us for is symptom management. And we really talk about treating total pain. And pain is more than just, I broke my arm and I'm having pain in that spot, or I've had an amputation, I'm having pain in that spot. Pain is, if you want to talk about just physical pain, so you've got nerve pain, you've got touch pain or nociceptive pain, got a lot of different types of pain, but then it's complicated by your cultural perceptions of what pain means or is, what you're allowed to show and express surrounding pain. If you're having any sort of existential crisis on top of the pain that you're having, why did this happen to me? Or what, if you have a faith, maybe that's, affecting the way that you're being able to cope, and that will affect your pain. And so really looking at total pain and all of the ways that we can treat it, not just pharmaceuticals, but what other options are there to support these families and their children, and what ways can we support them that are beyond just opioids. So again, kind of another way to look at this with our goals for what is the goal of our team getting involved, it really is to make sure that these children are experiencing just excellence in care, and that their families are being supported as well. Making sure they have a good understanding. What is this child's condition? What are the benefits and burdens of the treatments that they're being offered and that they're having to choose from? Who this family and child is, what they worry about. We focus on communication, and that is between the family and the family and the medical team, and the medical team and the medical team. So there are a lot of different people talking, and there are opportunities for communication to get blocked in a lot of those different places. And so we do try to be a part of that solution, as far as how do we make communication better so that this child continues to receive the best care possible. We help families with decision making. Again, all of us, for whatever different specialty you are in, we get a lot of education. We take a lot of time to learn the skills that we have. And so when we're talking about these things, it's very comfortable, it's very familiar. We can say, oh yeah, I would make that decision this way because I understand all these pieces. For a lot of these families, this is the first time they've ever heard these words. And to have someone who has the time and the experience to be able to sit with you and say, okay, well, let's talk about your goals of care. Let's talk about how you make a decision surrounding this medical intervention, those goals of care in this patient, and pull that together. Again, focusing on comfort and symptom management. And then I think the other piece that a lot of people are unaware of is that we provide, I would say, the healthcare team support. So all of the healthcare team, why are we doing what we're doing? Why is this family choosing what they're choosing? Do they have an understanding of what they're choosing and what education has been done? And really supporting the team from that perspective, because as many of you I'm sure have experienced, there is some moral distress on the part of the providers and care teams that are involved with these families as to, like, do we really understand what we're doing and why we're doing those things? So people often ask, so what happens? Like, so you get consulted and then you meet the family, and our KPC is Rainbow Kids Palliative Care. I don't know if I mentioned that earlier. First and foremost, we carry the child's story. For a lot of families, it is very therapeutic to repeat the story over and over again. For many families, it is not. It is traumatic. And to have to repeat it and repeat it and repeat it every time there's a new subspecialist, or every time there's a new admission to a hospital, or whatever it is very distressing. And so we try to be there to say, is this a time you want to share? Do you want us to talk to the team? Do you want us to be there when you kind of, go through this process? So we help carry that story forward. And it's comforting to the families to know that there are people there that have known them from the beginning, that have known what this child has been through, what they're fighting for, what they're hoping for and worrying about, and not having to redevelop that every time. But we start with an initial meeting. We sit down with the family and we just talk. We just let them inform us about them, their child, what's important, what we worry about. We try to attend care conferences. So when they're in the hospital, if there's a meeting with their teams, we try to be a part of that. And we do that for a variety of reasons. One, we take notes. We are an extra set of ears. We ask questions because we've seen other families go through similar experiences, and families say, you know what, I wish I would have known, or I wish I would have asked. And we try to be that voice of, like, well, what about this? I've heard you say that this is important. And then asking the team, is that something we can achieve? Is that a feasible thing for this child to experience? We attend clinic appointments. So if there are outpatient meetings or clinic appointments and the families let us know, we'll be there. Or if the team lets us know, there are occasions where, like recently, I was with a speech language pathologist who wanted an additional support there because she felt like the family wasn't quite understanding what was happening and just wanted the extra support to be able to help that connection happen so that we could, provide safe care for this child and not the family not inadvertently cause harm because they were not understanding. So we try to attend those appointments and clinic visits as able. We provide a family lunch. That has been on and off. It's been a little hard with since COVID, really, to reestablish that, but it is really just a place to connect with other families that have complex medical needs and children. We have a private Facebook page that it is really a pretty special place. So much of social media is very negative and kind of heavy. And this is one where they can go in and say, I'm going home with a trach for the first time, or I think I might need a G tube, or I think maybe we've got a diagnosis of CP, or whatever it might be. and reach out to families who have been there. Have any of you done this? How have you set up your rooms when you take home event? How do you take your child around when they have this much medical equipment? Like, what is life like? What are the questions you wish you would ask? And they share these things with each other and really, really supportive. It's also a great place for them to, they are done using they've got the trach out and they don't need their equipment anymore and they can donate it to a family that needs it. So things like that happen on our Facebook page, which is pretty great. You cannot find it unless we invite you in. So it is very private and secret. They're not going to be, their family and friends on social media can't see what they're posting and asking. So it's kind of a nice private space for them. We keep in contact. So we reach out occasionally if we haven't heard from them, or if we hear, they're having some changes. A lot of our subspecialties will call us and say, hey, just so you know, these things are coming up. There's these new struggles that we're finding out about. They just found out that there's a hearing loss or that there's a new cancer or whatever comes up. You might want to reach out to them, and we do. We perform palliative care assessments and recommendations. So we meet with that family, we figure out what they need from us, and then we make recommendations on how to change the care to better fit the goals for this child. And then we see them in our outpatient clinic as needed. I would say most of the time, what do they see us in the palliative care clinic for? I would say pain and symptom management is probably our biggest one, or advanced care planning. So we're in a different place. We've heard that our disease trajectory is changing, and we want to meet with you guys to discuss how we move forward. So when we meet with the family, it really is important to know who they are and who their child is. And we know medically, we can read the chart, but I like to hear from a family what their medical perspective is and who are they as a person? Who is this child as a person, as an individual? What is it that they like? What do they not like? What do you do as a family? What are you hoping that this child can participate in? And it really is spending that time to understand who are these people we're working with and recognizing that their values, their hopes and dreams are going to be unique to them and different than every other family that I've met or than from myself, so that I can figure out how best are we going to be able to support them. I like to know who their support team is. A lot of times that's family, friends, church. Sometimes it's just themselves. They'll say, oh, just my husband, my wife, my spouse, whatever, is my support person. So then how can we help get some more supports in place? Because as many of us know, raising a medically complex child, you need a village, truly. And so how do we help expand that or make sure that they have the support they need? Again, we talk about that medical understanding and literacy. Is their medical literacy excellent? Is it fair? Is it limited? Is there a language barrier? Do they prefer verbal versus visual learning? When we're having these care conferences, should we have handouts? Should we have drawings? What should we be doing to make sure that they are understanding what we're talking about? What are their hopes and worries? And, it seems so obvious. Like, I think when I first asked that question, and I usually try to say something like, you're in a hospital or you're seeing a palliative care team. I know you're worried they may not survive this. I know you're worried they might die. That isn't the only thing you're worried about. What else are you worried about? They'll talk about, I'm worried that what if they, never walk again? What if they never make it out of this hospital again? What if they don't experience joy again? And we talk, or what if this financially devastates us? There can be a lot of different worries. And then we try to really end on, and what do you hope for? And that varies a lot. Some families say, I hope I can just always see that sparkle of joy in their eyes. Like, even if they can't communicate traditionally, or if they can't walk or talk or eat, those things are okay, but there is a level of joy and spark that I can see in their eyes. And I want that to always be there. I want to know they're experiencing love. And I want to know they're experiencing joy. And as long as we're doing that, we're doing well, and we can keep going with what we're doing. And then once we talk about all of that, then I introduce them to this concept of goals of care. And goals of care is really the hopes and avoiding the worries. So if you're really worried about pain and suffering, and our choices are all going to end in similar outcomes, what is the least likely to be painful, right? If you're most worried about spending as much time at home versus in the hospital, and again, all outcomes are fairly equal, well, which of these paths is most likely to give you the most time at home? Sometimes those aren't options. Sometimes the most important thing is time. And their goal of care is time, and a little less focus on what we might consider quality. then we would focus more on, okay, now it might be more painful. It might mean more time in the hospital. It might mean these different things, but it will give you more time. That feels like it aligns more with this treatment pathway. And so we help them kind of sort out, what does that look like? What does that mean when you're asking somebody to put in a G tube, or you're asking somebody to put in a trach, or to do chemotherapy or whatever? Does that really align with what your goals of care are, what you're hoping for your child? And does it not, does it not then induce things that are burdensome or unwanted kind of side effects of the medical interventions? And then, is there any support missing from their care team? Did you just a couple days ago, did you know you could have visual therapy, right? Did you know that you could have these other pieces involved in the care and encouragement of development of your child? Nope, they had no idea. So we connected them with those teams to make sure that they were getting all of the additional supports that they wanted, because the most important thing for that family, and for a lot of our families, is ensuring that, developmentally they're achieving whatever their maximum potential is. And so connecting them there. Sometimes it's maybe finding a new pulmonologist that they can understand what they're saying, what they're trying to strive for. And so really just helping them connect with any of the pieces that are missing. And really the goal for our involvement, it's about what they want, not us. It's not our agenda, it's theirs and what they find helpful. And for some families, that is one very specific thing. They want pain and symptom management only, or they want advanced care planning only. And then the rest of it, they don't really need, because they've got it from elsewhere within their support system. Kind of touched on this, but really taking that, the goals of care, delineating what they are, matching what they want, what they're hoping for, with the treatment available. And is that even possible? And that is one of the questions I'll ask, because I sometimes will hear that question in the medical provider's voice or the healthcare provider's voice that says, I don't think that's possible. But it's a hard thing to say. It's a really hard thing to say. It's much easier to say, if I ask you, do you think that's possible, to tell me I'm worried it's not, than it is to look a family in the eye and say, we're not going to be able to do that. And so sometimes it's the more gentle, compassionate way to help providers say the hard thing, so that the family, who deserves to hear all of the truth, can hear that without kind of having it be really a conflict-ridden discussion. The other thing that we do ask about is kind of, like I said, this curative versus life prolonging versus comfort care. And it's funny, because I think in our own minds, we all think, well, everybody wants X. Everybody wants to be comfortable through the end. Everybody wants the longest life possible. Everybody wants, well, we want all of those things, but oftentimes, unfortunately, for these children, it is an either or. We can choose one path or the other, but we may not be able to do both. We always strive for all of those things. If I can give you the longest life and the most comfortable life and the best quality of life, that's what we're going for. But unfortunately, and as more and more technology progresses, things are getting more and more complex, as trying to make these decisions for families and children about what we can do and what's reasonable. We also do talk about what is left to be done. So if we are talking advanced care planning and end of life, and is this really going to be a shortened lifespan, are the things that are important. And I tell families, there are no stupid ideas. Please, please, please tell me anything in the world you think would be important to do, and let's see what we can do to create it. And that might be, I wish we had a family, this has been many moons ago, but a family who said, I wish I could take her home to the island I was raised on, but we're not going to be able to travel that far. It's, like a 20-hour flight. It's just not going to happen. So instead, what we did as a hospital was bring the island to the child. And so we got a huge, used to have a very large room that we could use, and we created an island space, and had the dancers and the food and the people and everybody come in and celebrate. So could we do exactly what they were hoping for? No, but we did do something in honor of that important kind of legacy and memory making moment. So there's always things that we can do, and trying to think outside of the box is a really big piece of what palliative care tries to do. Is like, we have that kind of that time and that perspective to be able to say, okay, well, that might not be possible, but what is? And then advanced care planning. So discussing what a good death is. And we like to do this earlier on, because it really is easier if there's ever an easy point. I don't think there is, but it is easier when you're not in the throes of a really difficult decision to be making plans. So to talk about, we know that this is a potentially life-limiting illness. If this goes the way that none of us are hoping it will, what does a good death look like? Would that be at home? Would it be in the hospital? Would you try to travel a bunch first? Would you try to just be, kind of hunkered down with the family at home? Like, what does it look like, and what does it mean? Does it mean, if they're old enough to engage with me in the conversation, Does that mean being awake and interacting with all your family and friends, even if that means that you might be hurting? Or is it having your family and friends around, but sleeping because you don't want to experience the pain? Like, what is it? What does a good death look like? And then again, preventing any unwanted or burdensome medical interventions, especially surrounding end of life and things like code interventions. If we know that doing CPR is not going to provide you with a longer, better quality of life, that is maybe something we don't choose to do. If there's some hope that it might, or if it means something to the family to say we tried everything and that for us is part of everything, then maybe that is the right thing to do. But being able to talk about that honestly and openly and not fearfully, so that we can really make sure that the care that this child is receiving is in line with their goals, their family's goals, their values and priorities. So if we are going through the dying process, we don't go away. Again, you're stuck with us forever. So we discuss things and support the child and family with symptom management. Primarily the big ones that we deal with at end of life are air hunger or the feeling that you can't breathe. There are ways to alleviate that, both non-pharmacological and pharmacological. A fan in the face is a great relief, as is morphine. Both of those things have huge benefit to relaxing somebody who feels like they can't quite get enough air. We deal a lot with confusion and agitation and pain. And so really making sure that we are addressing that and that the end of a person's life, child's life is not more painful or confusing than it needs to be. We talk about code status changes during that time. Are we at a place where we want to set a loving limit on what interventions we're going to do, or does it still feel like there might be enough hope in that we continue on with how our code status is now regarding intervention of CPR or other interventions that we do at end of life? There is a book called My 5 Wishes, and there is a child friendly book, a teenage friendly book, and then an adult book. And it goes through with that child and family what matters in the end. How do we provide support? What are the things that are comforting? What are the things that we do or don't want people to say or do around us when we're dying? It's a really great resource. And if any of you are interested, let me know. And then we obviously offer supportive listening. I often have families call just to say, just need to walk through this one more time. Like we said that they were gonna, die in this amount of time and they seem like they're still doing okay. So did we make the right decision? Are we still in the same place? Just being able to listen to them process out loud their decision making and if they're still comfortable with where they're at. We connect with hospice or inpatient support if they would prefer to die in a hospital or prefer to have their child die in a hospital, then we support them there. And if they prefer to be at home, then we connect them with the hospice teams and make sure that they can have the support that they want there. And I will say, we have children that go home everywhere. And some places do not have access to palliative care or hospice care in their area. And so what we have done is we have found home health nurses and doctors that feel comfortable being in constant communication with our team, and we find a way to support these families and these children. And then after death, we continue to follow with these families. We send cards for 3 years on the anniversary of their child's death to just remind them that we still remember them, we still think about them. We call them about 2 to 3 weeks, sometimes a little longer after the death, about the time that people start to fade away and aren't as like, are you okay? Are you okay? And they aren't as busy because that tends to be the harder time for a death. That first little bit, you're kind of in shock. You're really busy. Lots of people are showing up. You're getting a lot of casseroles at your door. All of these things are happening. And then that fades away as people get back to their lives, but your pain hasn't faded. You are trying to reach does not have a so we'll follow up at that point. We do, people ask us if we attend viewings or funerals, and that is a personal choice of both, the team member and the family. So oftentimes it's very clear if the family would like you to attend, and it also needs to be something that aligns with you emotionally as a provider. And I try to go
Thank
to.
you for calling University of Utah Health. Your call may be monitored or recorded for quality assurance.
I have learned that attending viewings works better for me. Funerals are longer and harder emotionally for me, but I like the viewings because I like them is the wrong word, but I prefer the viewings because I can see the family, I can connect with them, I can say goodbye, I can show them that we care, but it doesn't weigh on me the way the funerals do. And so for me personally, that's how I've decided to manage that. And each of the team members is different and each family is different. And then we try to connect them, if they don't know about the bereavement support that are available through Primary Children's or through their community, if they don't live locally, we try to connect them with that support so that they get the counseling and the supports that they need. they need. And then we're also just someone, we'll have people call, months to years out and just say, nobody really knew my baby because they were in the NICU the whole time, except you guys did. And I want just, do you remember when they did these things? And it's just this connection to someone who really knew your child and knew the struggles that they went through and how great they were and all of these things that maybe other people didn't because their life was in the hospital. I think it's really important to say, what does palliative care not do? We do not talk patients or families into treatments. We do not suggest treatments that were not offered by the medical team. That isn't our job. Our job is to support the family and just help them sort through the information. We don't replace any part of the team at all. We are an addition to, we are not a replacement of any part of the team. We don't focus on dying. I know we've talked a lot about end of life in this talk, but we don't actually focus there. We focus on living well. And sometimes that's living well right to the very end. But that is our goal. And one of the palliative care teams that I'm aware of calls themselves the quality team or the quality of life team. And that really is our biggest goal, is to make sure that what we are doing, we're doing to give your child and you as a family the very best quality of life possible, despite the many challenges that you'll face being a medically complex family. And we don't provide 24/7 coverage. We do because of a lot of our physicians are also on our hospice team. We do have a hospice doc that is 24/7, but we don't have the full team support 24/7 yet, unfortunately. So I think a lot of questions, why doesn't every medically complex child have palliative care? This is it right here. So I think this cartoon is certainly meant to be lighthearted, but it is also the perspective that people have. They think that we're going to come in and just talk about death. That's what we're going to start with. They'll say things like, we don't want you to crush their hope. We don't need you yet. We don't know their prognosis or their life expectancy. These parents would still do everything. And we're here for all of that. We want to be a part of this journey for this family, no matter what their path entails and what they choose. So there is really not you can't get us involved too soon. Excuse me. And we don't want to crush their hope either. So this is not a problem that you need to worry about. And so people often ask, well, your discussions are really heavy. So how do you have these discussions, these scary, big discussions, and not scare families away? How is it that they do feel comfortable and safe and often joyful around us when we're visiting and talking? And it boils down to one thing, and this is why I wanted to touch quickly on some of the communication styles that we use. And I think the biggest thing is that this is really the way that we operate. We listen to understand. We don't give judgment or advice. Sometimes we'll give advice if it's specifically asked and we have that capability, but more often we'll say something back to them about, well, I think you have said that this is what's important to you. So would that feel more in line with what your goals are versus giving advice? We address emotion, which really in the healthcare community, we struggle to do. And it is so crucial to be able to get people back into their frontal lobe, to be able to hear what we're saying and take in the education that we're trying to do with them. We acknowledge that this is hard. We acknowledge that they're amazing advocates for their child. We acknowledge this is scary. We also acknowledge that while, there was a quote from one of my colleagues who said, these families experience the lowest of lows, but they also experience because of that the highest of highs. And so we kind of can see both sides of that and acknowledge both the joy and the struggle within their lives. And we can sit in silence like nobody's business. It's really hard to sit in silence, but it is this presence that says, I'm willing to get down in this deep, dark hole with you, and I'm willing to sit here, and I'm not scared. I'm not scared of your emotion. I'm not scared of how hard this is going to be. I'm here with you. You are not alone. And that is a huge impact for families. Emotion is really involuntary. What you do after can be changed, but that initial reaction that we all as humans have, it happens. What we do next is a different story. And what we do as providers and team members, helping them is to acknowledge that emotion. It allows them to hear us to be able to move forward. So anytime that you're with a family and you're educating, you're like, we have talked about this 33 times and you still are not hearing me. It is probably because you're missing the emotion. They're probably still in their fear base. They're back in their amygdala, their lizard brain really just going, I cannot believe this is happening. What is it? What do they mean? What do you mean my child's never going to do X, or that it's going to require all of this intervention to be able to get to this point, to be able to say this must be really scary, really brings people back to you. Like they connect back to you and, oh my goodness, you're right. This is really scary. So nurse is a great way to do this. Anytime I've repeated myself a few times and feel like, nope, you're not hearing me, they're not making eye contact with me, they're not doing what I'm asking them to do, I try to use one of these statements. So naming it, gosh, it seems like you're pretty frustrated right now. I would be too. Or, you know, a lot of families in your situation would be really angry if they were dealing with this. Wonder how you're feeling. Understanding, I'd be worried too. I get why you're worried. Respecting, you are an amazing advocate. I can see that you are trying so hard to advocate for your child. And that's especially sometimes I think when you have a family that's really angry or really frustrated, to be able to say to them, I see you. And I see that even though you're demonstrating anger, that what you're really trying to do is be heard so that you can advocate for your child. Now, whether they're doing it in a way that is therapeutic or beneficial, that's a different discussion. But to be able to see that and see that that's what they're trying to do and the connection you can make with that family by acknowledging that, it will de-escalate a situation faster than almost anything I've seen. Supporting, you know, we don't always have the answers, but we can say, I know somebody who does, or I'm with you while we try to find these answers. And I'll tell families, we may never find an answer, but I'm going to be right alongside you on this journey while we try to figure it out. You're not alone in this. I'm sorry that you have to do this, but you're not alone in this. And then exploring is my favorite. I will continue to explore until I can repeat it back to the family and they can say, yep, that's what I meant. And I really, especially if I have this moment of like, well, your goals are really, that is not going to happen. Like if that's my internal reaction, I'm not understanding something. And so then I explain more, tell me more about why you're hoping for that. Tell me more what that means. What does that mean? What does that look like for you? And just keep going until like, okay, I understand. Because you've been told 25 times that your child is never going to eat and then they did. Now that we're saying your child is never going to walk, it's hard to believe because you've had that experience. That makes sense. I think we can maintain hope and worry at the same time. I like to give phrases to avoid. Euphemisms are terrible. They are space fillers. They are because we hate silence. So it was a blessing. This will make you a stronger, better person. Not helpful. Knowing exactly how you feel or can't imagine. Can't imagine is a little bit of a different thing, but knowing exactly how someone feels, not the case. Even if you have the exact same scenario, but you could say, I wonder what it might feel like to be in this situation. I wonder what you're thinking or feeling. Here's what happened to me. Let me tell you what I would do if I were you. That takes the focus off the family who is in crisis, who's actively trying to learn, who's trying to be with their child and puts it back on you. Never the goal. Really keep it focused on them. What do you want us to do? This infuriates families. What do you want us to do? Well, I want you to send me home with a healthy, happy child that does all the things that a neurotypical child would do. Can you do that? And if not, don't ask me what I want. Like, help me see what the potential is right now. And then the last two are just things just try not to use because futile and incompatible with life. In this day and age, first of all, the definition of like when life starts, like people say, well, my baby, like I carried my baby for 6 months, or my baby was born and lived for 2 weeks, or so what do you mean they're not compatible with life? They lived. So being really thoughtful that that's just not, and there's no benefit to that language, especially in discussion with the family. And then fetal care is becoming obsolete because what does that mean? Because every day new technology is developed. Every day we do things we didn't think we could do yesterday. And so now things that are not medically beneficial, you know, I'm worried that if we do this intervention, that's not going to benefit your child in any meaningful way. And I worry that in fact, we might be just doing things to them instead of helping them. What do you think about that? Does that ring true? Or does that feel like I'm wrong here? And really being able to say like, am I wrong? And then withdrawal of care, when we're talking about end of life care, that is not the case. We are removing aggressive medical intervention, but we are not taking away care. We're going to care through the end. And withdrawal of care is really a painful thing to say to families and also scary. What do you mean you're not going to care for my child anymore? Phrases you can say, I'm trying to imagine what you feel, focusing on comfort and dignity right now. It's beautiful how you put your child's needs before your own, because really to be able to make certain decisions, that is what they're doing. This sucks, just being real, being honest. This must be so difficult. Help me understand what you're thinking, you're feeling. I'm sorry. I'm really sorry that you're having to go through this. You're amazing and you're strong, but I'm sorry you have to be. And then finally, educationally, like if I have to teach them a little something, but they're really in this place, you know, I hope your child learns to walk. I would be over the moon. I'm a little bit worried because of the bleeding that we've seen in their brain, but I'm really hopeful that happens. But let's talk about what if this worry comes true, then what do we do with that? Like, how do we address that? And then finally, silence. I can't tell you enough how much silence matters. Just sitting, it really does speak when words can't, and it makes a difference. couple of things I think you've probably experienced is you're like going through a session with somebody and they're like, yeah, well, you're wrong. They're going to prove you wrong. There's going to be a miracle. Great. So tell me more. Like, what do you mean they're going to be okay? One time I had a family, child was going to be neurologically devastated. We got called, family kept saying, everything's going to be okay. So I went in and she said it enough times. I said, I keep hearing this word okay. What do you mean by that? Well, she's going to know she's loved. I'm like, oh, so you don't expect her to like walk or talk or eat. She's like, oh my gosh, heavens no. Have you seen the reports? Do you know what's going on? No, that's not gonna happen, but she's gonna know she's loved. I'm like, oh, I guess we can all calm down a little bit because in fact, the goal of being loved is a very achievable goal. She already is, right? She'll prove you wrong. Would any of us turn down that or turn down a miracle, hoping for a miracle? I hope so. I would love a miracle. I'd love to be part of a miracle. So yes, please. I don't worry about the fact that I don't think a miracle's coming. It's not my job. And hope, you can hope and worry at the same time. It can live side by side. And I think the more that you can do that, the more you align with families, the little less resistance you get for whatever intervention it is you're trying to help them achieve when you can say to them, I'm with you, man. Here's, again, here's why I'm worried, but I'm with you. Let's see what we can do to optimize things. And then I like this, so many times we expect families to behave a certain way when they're in a certain situation. But if you were ending up at the same place and you knew hope and despair were the paths to that same destination, which one would you choose? All right. Questions, thoughts, anything? Blow your faces up so I can see you here.
So Jamie, this is Janelle. You had said a comment, and I'm gonna have to go back and watch the recording. I wanted to pause you and say, will you say that whole sentence just over again? Because it was such a great one to do, to say. I love those phrases that you just talked about.
Thank you. Yeah, we so hard, like we're such fact-based people, I think, in healthcare. That I think sometimes just taking that time to sit with families and say, I see you and I hear you. And I'm not going to throw facts at you. I'm just going to sit with your situation that you're in and the pain that you're in or the struggle that you're in. We're just going to sit here with you and be present. It really does make a huge difference for our families.
Yeah. And then Katie put in there, she loves this phrase, instead of don't just sit there, do something. She said, don't just do something, sit there.
Yes. Yes. My favorite, if you want, there's a child's book called The Rabbit Listened, and it's such a perfect description of why silence works. And it's very cute. It's very short. But the rabbit listened and he ended up being the most therapeutic person, right? Because everybody else, the bear came in and roared and growled and all these different characters come through, but really it's just being able to process your own information that you need more than you need somebody else to process it for you. So I like that. We'll put that on our board.
And then Jennifer Young says, how do we refer to you?
To how would you make a referral to our team? Is that what you mean?
Jennifer? Yes.
Yeah. So you can, so it depends on where you're located, but if you are within the IHC primary children's system through iCentra, you can page us. Here's the thing that is hard, and I don't have our pager number, but I have our office number. You can page us and it will say, hey, somebody somewhere wants you to consult, which is not helpful. So if you just call our office, which I will give you that number, it's 801-662-3770, and I'll put it in here. And then it's option 2. Oop, if I could type, option 2. And just talk to us. And we will tell you who we need to have an order sent from. We'll help you walk through that process. If you're in Primary Children's Hospital, you can have the primary team, whoever that child is with as the primary team, they can put in an order and it will prompt them to page or to call us. But if you're outside of that system, I think the best thing is probably just to call us and have us walk you through what information we need and where to fax it to.
Great. And then Katie, do you want to come unmute and just ask your question?
Hi, thank you, Jamie, for your talk. I really feel like all of us, all providers, and including medical teams could benefit more from having the perspective that palliative care provides. Um, I'm wondering from like a lot of us are in early intervention and outside of like the Intermountain system. So I'm wondering how that like could we encourage a family that we feel like would be well served by your services ask for a referral? Can they self-refer to you guys? How does that work?
Yeah, they can self-refer. Absolutely. They can call that same number and we would walk them through. I will say for most families, it's pretty intimidating. And so I would still recommend like if you could call and say, I have this family, here's their primary care physician or one of their subspecialists. Like if you could connect us to one of them, then we're happy to reach out to the family and say, hey, we got notice that you might benefit from our services. We'd love to talk to you and help make that connection for them. Always tell them like, hey, there's this, and I don't recommend using the word palliative care unless you're super comfortable describing it because so many people don't know what it is and they think it's end of life care. So what I tell people to say is there is a team called Rainbow Kids who is a support team up at Primary Children's that I think would be really beneficial for you. And it's for complex and chronic medically complex children. I think it'd be really beneficial. Is it okay if I put in, a request for them to call you and see if it's something you'd be interested in? And then we'll tell them we're called palliative care and why it isn't anything to be afraid of. But yeah, I would say if you can make that kind of first connection, it's probably more successful. Some families, them, they're like, oh yeah, I'll call, no problem. But most families are like, you want me to call what? Like it feels weird. So, yeah. And I think I just saw this other comment. As far as tools for like supporting families to going through hard things, there are other options for everyone kind of across really the country. So Vital Talk does do virtual and in-person classes, the Mastering Difficult Conversations. And it's a lot of what I just talked about, this sitting, being present, using the nurse statements. That's where that comes from. There's a bunch of other tools that we can use. They're also at the university in primary, we do a program twice a year called UCOPE, which is the Utah Certification of Palliative Education. And you can look that up. It's in like 2 weeks and then again in the spring. But it's a 4-day course where in the morning it's didactics of how do you have hard conversations. Some stuff isn't relevant to everybody. Like symptom management, may not be relevant to a lot of people, but we try to make all of it relevant to communication pieces when you are dealing with medically complex people. And then you practice in the afternoon actually having these conversations, which sounds terrifying, but it's awesome. So that's a resource as well. And then the University of Utah has programs specific to communication. UACT is one I'm thinking of, but I can't remember the qualifications. Oh, thanks for putting that in there. So there are varieties if like this is something you're interested in, learning some new phrases or some new techniques to be able to help make connections, especially with those families that are really fearful and kind of blocking and pushing away what you have to offer them. It's nice to be able to make a connection with someone and have them finally be receptive to what you're trying to help them with.
Well, great. Jamie, thank you so much. I think that was just a beautiful and needed conversation, so I appreciate it. When we were going through this discussion as a hub team, we were also all thinking about how do we navigate these conversations around the families that we serve. So that is going to be our breakout groups today. We are going to be talking about how do you and your programs support those providers when they're experiencing these loss of the families that we work with, or how do we support the families? What does your agency do to navigate these situations? If you have been a provider who has been through this situation, how do you find balance in supporting yourself as well as the family? And then how do you continue to support the family after death? So Shayna's going to go ahead and put us in our breakout groups and just having a discussion about this. Welcome back. Hopefully everybody had some great discussions with it. We do have a few minutes to go over one idea or one thing that everybody's group talked about. So Rebecca, I'm going to start with your group. What was one idea?
Okay, I'm just going to share a little tidbit that Jamie shared right at the end, and that would be to think about having a grief ritual for your team where your team has space to maybe say the name of the child or read out a little poem. Maybe have a few minutes of silence when your team loses a child in one of their families. So I like that.
Oh, that's a great idea. I love that one. Thanks for sharing. All right, Pat, what about your group? You're on mute, so I'm sure you just gave a brilliant idea.
No, I said I have nothing to add because I just talked. So Kate took the notes.
Okay, Kate.
Yeah. Something that I appreciated was there was some more conversation about other phrases that we can do to say to help connect with families when they are opening up with about their emotions, and just validating them that it's, you know, of course it's hard having some stranger come into your home and talk about your child's development. Thank you for sharing with me and choosing me to share those feelings with. I like that.
Oh, that's a great one too. All right, Heather.
Yeah, so we had talked about how our agencies navigate these situations, and there was great conversation around, rallying with the providers to perhaps attend the viewing or services for the child. One program talked about how it's just their practice that they give the book tier suit to the parents, and then individual service providers may give the parent a gift. Another program talked about some really incredible groups that they offer, as well as group mood, where these families who are experiencing a loss, so they have a child lost group and a medically complex group, and these parents, even after they've graduated from early intervention, can continue to participate. And what a gift that has been to these families who may not want to go back to primaries because that's a trigger for them, not just it's going to activate some trauma. And so that's been giving them that platform and permission to connect has just been an incredible gift. And I was really impressed as I was learning about that program.
That's awesome. Great. And so then Shelby.
Yeah, so we had a lot of really great discussion. Our question was about how, finding balance, you know, in your personal life when dealing kind of with some of these more sensitive situations. And I think one of the biggest things that I really liked was, you know, a lot of times when we do work with these families, we have a lot of emotions and we just kind of have to try to push them down quickly because maybe we have another visit we have to go to, or we just kind of, that's easiest for us to just push the emotions away. So we kind of talked about making sure to just kind of sit with those emotions, identify where you're feeling them, if it's a tight chest or maybe an upset stomach or, you know, whatever it might be, to just kind of help ground yourself and I guess kind of deal with those emotions a little bit more productively than just pushing them down and ignoring them.
Yeah, gosh, those are some great topics and tips that you guys had. So I'm really excited to read through them all. If you each will send those to Kate Bennington, she did just drop her email in there. So if you guys will send those to her, we will compile all of those and they will be on our Canvas page for everybody to go back and look through. Again, Jamie, thank you so much for today's session. Super helpful. We are wrapping up our NICU Part 4 series next month, and I believe that Pat and Rebecca are both presenting for us around some feeding and NICU stuff. Nope, not feeding. What is it, Pat?
I'm going to delineate all the weird, sort of unusual, very rare diagnoses that are seen. And then Rebecca's going to talk about managing those kiddos in a rural or like a rural environment where you're not like living right next to primary children's where you can just run over all the time, and sort of how the providers support the community, have the community support that family. So isn't that right, Rebecca? Where are you?
That sounds good, Pat.
Okay.
Yay. Well, so
We need
hopefully,
Cases, need cases, need
these
cases.
cases.
Yes.
So case studies, reach out to us. All right. Well, thank you. All enjoy the rest of your week. Hopefully we remember that it's Wednesday, not Tuesday or not Friday. I'm not sure what day it is. So
Thanks so much,
Well-
Jamie. That was great.
Thanks, guys. Bye-bye.